Well, thanks everyone for joining us. As she said, my name is Sanjay Iyer. I'm a movement disorders neurologist. I've been with the practice since 2019. I'm also serving as medical director at the moment. But it's my pleasure to introduce Dr. Anita. Dr. Anita Dr. Wu is somebody that I've had the pleasure of knowing for almost more than 10 years at this point. I remember we were both working over at a large healthcare institution here in town, and there's news of recruiting this top-notch neurologist from New York City. And we thought, wow, the big city. So, amazing credentials. And we were just excited that she was coming down here to join the system. Over the years, we've shared a lot of patients.
I'm unmuted, and I don't know.
We, as physicians, when we see patients that have been evaluated by other physicians, you really get a sense as to, how thorough is this doctor, what's going on in their mind, and when the way they document different things. And whenever I would see patients that Dr. Wu had seen, I was always amazed at just how detailed she was, how organized she was, and how she had really thought through all the complicated possibilities in terms of diagnostics and the workup. So always thought a lot of her work, and so glad that you're finally here. But just to begin with, we want to learn a little bit more about you in general. Like, where did you grow up?
Sometimes they'll cut in on that.
So my parents are from Taiwan, and my dad came over to get his PhD in urban planning, and my sister, who's 6 years older than me, was born there. And so I was born here in Maryland. They moved, as often immigrants do. They were in Wisconsin, Knoxville, Tennessee. I'm probably forgetting one place. And then I was born in Baltimore, Maryland. And I grew up in Maryland, Baltimore, and then a little area in between Baltimore and DC called Columbia. And then I spent high school close to DC and Bethesda. And I have, so it's just me and my older sister and my parents, and they had a tight-knit community of Taiwanese friends in Bethesda, or that Maryland area. And then I went off to college in the Northeast. I went to Yale, and I was an English major, believe it or not. It seemed like a really good idea to read novels and get a degree. And so it was a really good idea. And then sometime around junior year, it hit me that it wasn't that fun when you had to write really long papers afterwards. It took some of the fun out of reading. And then I also started to think, what do I want to actually do? What does it mean to work? And by that point, I had been a camp counselor. I had waitressed. I had done, I had volunteered in hospitals. I was interested in a lot of things, and I decided to become a doctor. And so then after I finished college, because I hadn't started all the medical degree stuff until the end, I had to finish my science classes. After I worked for a year in consulting. That solidified that that probably wasn't going to be. I probably didn't want to be in business, but it was a good experience for the year. And it was always good to have a paycheck. So did that, and then I got into medical school, went to Stanford. And then I went to Cornell. I was in New York City for my residency. And basically I was there. I had kids, 2 kids. We moved here in 2010 when they were 4 and 7 years old. So Charlotte is their home. And so it's our home now. And that's, probably around the time that we met. We are, as it so happens, our two of Dr. Iyer's daughter and my son are in the same grade. So we might have even met that way. Mm-hmm. My son is a great student, but his daughter, wow. So, anyway, there's that. And I came here, and I was a stay-at-home mom for about a half a year, and I realized something's missing, time to go back. And then I ended up, with you for a while, and then I was there, and then now I'm here. So I don't know. That's kind of the.
Did you meet your husband in New York?
So I met my husband when I was at med school at Stanford, and then and then we moved out to the East Coast. He's in business, so that was easy to be in New York City. That worked out well, and that was part of doing residency in New York City. It was good for his career at the time. So,
Do you guys have any pets?
we just got a post-COVID dog. I'm really slow with decisions. It takes me I had heard, which is now I know true, that having a dog is like having half a baby. And that's about right? And so my husband didn't have a pet growing up, and I didn't have a pet growing up. But in Charlotte, you just see all these happy people walking their dogs. And I kept hearing about everybody's pets in the office, and there, these signs of I work hard so that my dog can have a better life. And just I just started. I was drawn in. I was drawn in, and so we got a dog about a year and a half ago.
Wonderful.
So,
well, you talked a little bit about your training and how you sort of got into medicine. What about neurology? What captured your mind? What made you think about neurology as a profession?
Yeah, that's a great question. I think because as I went through the rotations in medical school, it was just so clear that neurology was so much more interesting. Now we know that everything is just so intertwined, and in the body, but elsewhere also. And I think I would just go through each rotation and thought, okay, well, that's interesting, and that's how the heart pumps, and the electrophysiology is really interesting, but what about that person? That's what I was so interested in. I think that was part of being an English major, the story and individual is so important. And I think a lot of that is captured in neurology. And it's probably had that intersection between the body but really what seemed to me to be the person.
Yeah, I think it's interesting because as we go through the medical training, we spend 4 to 6 weeks, sometimes even longer, in each area of specialty, whether it's surgery, whether it's GI, cardiology, dermatology, all the different areas. You rotate through them, and I remember going through it and thinking, wow, this is interesting, and yet there's no way I could do this for the rest of my life. I love kids and they're great, but there's no way I could do that for the rest of my life. And you kind of work your way through it. And when I got to neurology, as you said, it's the story, it's the person behind the disease, it's sort of everything and how it's all interconnected. And the brain is just so fascinating. I think that's what draws so many of us to it. So you had the opportunity, you've worked in a couple of different large healthcare arenas. I think one of the things that jumps out on your resume that people are always curious about is that you were also the neurologist for the New York Mets, and I wasn't sure if that was because my Atlanta Braves were always clobbering them, but didn't know kind of what that experience was like.
Yeah, I wish it was more interesting, to be honest. And then I listened to some of Dr. Edwards' stories, and I thought, oh my gosh, they hired me even though I didn't play lacrosse in college. Wow. But I think it was I bet if I were a huge sports fan, it would have been super interesting. But I think good and bad, I think everybody is important. And so with the Mets, it was sort of interesting because I didn't realize when I was asked to do it that you take care of the whole team. And I didn't really understand, this is how naive I was, that there's super minor league and then there's the actual Mets players. And I didn't, and the whole infrastructure of the, you know, the owners and the you know, the managers and all of that. But I remember realizing over time that I could distinguish who was important because the minor league players would take the subway because I was in New York City and go out by themselves. And then I realized, oh, the whole office is really excited and this person is coming with a trainer and we have to open the back door and they're making sure like there was extra people in the office like cleaning the office. And so they're probably, so I, you know, but it was definitely interesting. We got like free tickets. I actually never used them until I was moving. I gave them to people actually. I would say, oh, you can always have, you know, you guys can bring your family. And we never went because my kids were so little then, but I think I had like our babysitters go or neighbors go.
I'm sure they loved working for you.
I know. And they would call and they would say, well, I'm sure you saw that on TV and you're going to have to get them in. And like, oh, no, but
The fast
are
ball
they
to
in
the forehead.
season? Yeah. And then I didn't realize they're in season like all year. So, but less exciting than when we played.
So to change gears a little bit, what attracted you to MMC? Was there any personal connection to Parkinson's or dementia, or was it just a feeling you had that this is sort of where you belonged, or what?
Yeah, it was a lot of things because I have to say I love being a neurologist and I did enjoy, I liked, you know, am I allowed to say Atrium's a great place, and I really loved being a neurologist there. I think part of it was that one, sharing patients with you, that was kind of the same thing over time. I was referring some patients and I realized, wow, they're being taken care of so well over there. And that whole team approach that I think it's hard in a big organization. I tried to do it myself and I like to think that I sort of did it for my patients, but it's hard when you're kind of all by yourself as a silo in a big place. And I think I saw, you know, I would send patients and I realized that, you know, I sent them because Dr. Iyer's brilliant. And I was like, well, I can't figure it out. Let me refer. And so, but, you know, in addition to having your brilliant diagnoses, you know, the team approach really struck me over time. And that was sort of the beginning of it. And I would refer more patients. I think your nurse told me, oh, we've gotten a lot of referrals from you recently. Once I discovered, I started referring more patients. And then I think I told you, Dr. Iyer had sent emails in the past for recruiting, and I would tell other people. And then this year I got the email and I thought, what about me? And I just thought, wow, I'd love to be there. And then I got in contact with you and I was so happy that you thought it would be a good fit. So it was a lot of things. I think it was evolution of me as a physician and seeing the care that's given here in not just the medical aspect, but you realize as a physician, I think over time, you know, at first you think, oh, okay, right, it's just that prescription, but boy, it's much more about the whole person, and it's really hard in kind of big healthcare to do that. So.
Yeah, no, I agree. I had a very similar experience to you when I was in your shoes, and I knew Dr. Edwards for a number of years, and I would refer some of my patients to him. And what was interesting is one of the families came back for a follow-up visit when I was across the street, and the spouse, you know, the caregiver, as we called her, she looked so much less stressed out. She looked at peace. She looked like she had much better control over the situation and what was going on. And I asked her, I said, you know, what's different? You know, you just seem so much more at ease today. And she said, you know, honestly, the way they do things over at Dr. Edwards' office is I get as much time as my husband does. They want to know how I'm doing. They want to know how they can help me be a better caregiver. And that really struck me. And I think, those are the things that we tried to do in our own practices, but without the team, and it could be very hard to do, despite, how much energy you put into it. And that's what really really struck me is wow, the entire family is in a better place because of what they were doing over there. And I was thankful that he invited me to come and join as well. So as we kind of talk through a few other things, tell us about who some of your favorite musicians are.
I'm very lowbrow, so there's a lot. Like, I'll drink coffee from like a machine, and it tastes almost the same. I saw Dr. Edwards like doing some fancy thing with coffee. So I don't have my dad will listen to classical music. I played some piano and violin growing up, but probably like Michael Jackson.
I've heard of him.
That would probably be one of my favorites. But I like I like music in general, but very pop.
I think growing up, or not growing, but having kids about the same age, we were probably exposed to a lot of the same things and some of the current music that's out there. But there's a lot of buzz lately about some of the new treatments with Alzheimer's disease. There's one drug that's been approved. There's another one that's soon to be approved. It's sort of curious, what's your take? Where do you think this is going?
Yeah, it's so interesting. It's fascinating that I'm coming over at a time to a place where, in a field where we didn't have anything different for 20 years, and then being on this precipice really of potential change. And looking back, I hate to admit this, I stopped reading the articles about treatments because I learned years ago, oh, well, that's going to fail. Don't even bother reading the phase 1 trial. Mm-hmm. But it's really exciting. I think that we've learned so much about learning about how to prevent it for all of us with things like exercise, taking care of our cardiovascular risk factors, etc. before all this, because you still, even though we have these, I think one thing I've learned in medicine in general is best not to get it. The medicines don't do everything still, and I'm very excited, and I think it will change things a lot, but it's just one piece of the puzzle. And the other thing you realize as a physician over many years is, boy, your medicines depends on the person, but can be really harmful sometimes. And, I sort of half joke with my patients when I prescribe something sometimes, boy, you've got a 70% chance of thinking, Dr. Wu is so smart, or you have a 25 and a 30% chance of thinking, I'm never going back to her. And you can't take credit for, you learn over time, you can't take credit for the wins all the time at all. So with medicines, these medicines have some side effects, and you also realize you really learn them over time. The trials are one thing. Using them in, on large populations is going to be a whole other thing. So I'm really excited because I think it's really going to transform things. And I think, this place is a really exciting place to be for that. And I think because of the emphasis on the whole person, it's a really great place to be able to analyze whether that'll be beneficial and for that person at the time, but then also assess it over time. So it's not an easy answer. Yeah, I wish, I'd say, oh, great, we're going to solve it. We're going to be out of business. It'll be perfect. We'll find, you and I will go find some other jobs or something like that. That would be great. But yeah.
Yeah, I think it's one of the hardest things to learn as a physician is restraint. You're in the mode of always trying to fix something, always wanting to make something better. If there's a medication, we've got to use it. We've got to try it. over time, you start to realize, as Dr. Wu said, that you can often make some people a lot worse than what their current situation is. And so you have to be very careful. And, while we are very excited about these latest breakthroughs and what's sort of happening in the field, I think we do have to exercise a little bit of restraint as we're learning more about, how these therapies are going to impact people as well as, different individuals and large populations, because that's, nobody wants to, treat Alzheimer's or Parkinson's any, more than we do. At the same rate, we also don't want to do things that are going to make our patients worse, because that's not a good feeling. So one of the common themes and difficult discussions we have here in the office always centers around driving. And so tell us, how do you handle situations where, the family is adamant, they don't need to be driving, he shouldn't be driving, it's dangerous, and yet the patient is saying, I'm fine to drive and I'm going to keep driving and there's nothing you can do about it. Those are daily conversations here. And how do you try to handle those kinds of discussions in your practice?
That is probably the hardest questions. Now I'm seeing all new patients, and of course, for me, and my biggest fear is at that first visit, I'll have to tell someone not to drive, because you're trying to establish that one, trust, and then to take something away at that first visit is hard. But it's one of the hardest. There's never a black and white. Well, sometimes there's a black and white answer for that, although the person themselves may not know that. And so I think I try to assess the situation. If it's black and white, it's black and white. And if the person themselves doesn't recognize it, you have to figure out some way for safety for all, themselves and society, to either say or somehow lose some keys, or something else for driving. And then there's a lot of gray area, and we do rely a lot on professionals too. So there's, the driving evaluations, if we can do that. We did this, frankly, with my own mother-in-law, where I said, why don't you drive with Nana and see if you would send our kids in the car? And so there are things like that type of assessment, which I think are equally valuable. And so it's a tough question. And again, just like with everything, you read the textbooks and they'll say, okay, right, MMSE above this, or okay, get that start donepezil 5, and everything is very individual.
Yeah, it is a tricky discussion, because driving is independence, and when people can make good rational decisions, then they often will step away from driving when they realize, my dad called me one day and said, gosh, I've noticed that my reflexes are a little bit slower than they used to be, and I don't feel comfortable driving at night anymore. And I said, well, that's great. I'm glad you shared that. And, if you need to go somewhere at night, we'll make sure that you have a ride and those kinds of things. But, unfortunately, when people develop dementia, their ability to reason and make those good decisions can go away. And I remember one of my patients, the family didn't want him driving, and he didn't agree. And at one point, his son came to me and said, what do I do? I said, look, you're just going to have to call him and say, I'm coming over there. I'm going to take your keys. And that's the end of the story. And he said, Dad said, you better bring a gun. And, so again, it's a heated discussion, but again, it's something as physicians, I think, it's part of our responsibility in terms of safety to everybody. Besides driving, and in terms of safety issues, are there other particular safety issues that you look for that we need to stay on top of?
There's so many. There's, of course, guns is, of course, a big one. And there are just a myriad of things, beyond that, but it depends on each person's individual situation.
One thing Dr. Edwards kind of shared with me a couple of years ago, he said he was noticing more and more in his Alzheimer's patients that he was seeing different challenges with mobility or with balance. And I'm just curious if you've seen some of that same overlap in that population with risk of falls and other things. Have you noticed tremors or other things in some of your dementia patients?
Yeah, I think there certainly as part of the disease process, there in the later stages, there are some physical things that happen. And then the early stages, there can be some subtle visual or just planning, why don't I just carry all of this down the stairs? And, so executive function that's not working so well, that may lead to a fall. And then for all of us, because balance is not just the planning and the muscles, but the joints, the nerves. And so, and then there could be superimposed Parkinson's or tremors and all these things. So definitely, as we get older, I think I venture to say nobody's knees at 90, as I always say, is great. So that, all of that always plays a role. So definitely. And that's something that we didn't, when in the 2000s, when I was early 2000s becoming a doctor, we didn't even talk about that with our patients, but it's obviously such a, we've realized over time it's so important.
Yeah, absolutely. If you could be any animal, what would it be? And
Gosh. I feel like I should be allowed to think about that longer. But I mean, now that I have a dog, their life seems pretty good. So maybe a dog.
Sounds like a good answer to me. So again, it's been a pleasure talking to you, getting to know a little bit more about you. We're just so thrilled that you're here and the impact that you're going to make on the practice as we move forward. And I'd like to open it up to others who may have some questions or, like to further ask Dr. Wu a few things, or
so if anyone
here in the room or on TV.
If anyone has questions in the Zoom audience, in the room, just speak up. And in the Zoom audience, I probably won't see you if you raise your hand, so don't do that. But you can turn on your microphone and speak the question, or you can type it in the chat box, and we will happily read it. So opening it up.
I'm new, so nobody here would know me, but I have had some experience with a neuropsychiatrist, and it's been helpful. What do you do that's different from a neuropsychiatrist, and what would be the different, just generally the different approaches?
Good question. So neuropsychologist or neuropsychiatrist?
Which?
Psychologist.
Neuropsychologist.
So I would say that in the early phases, and I think neuropsychologists, they may operate a little bit differently, some of them, but usually they're more in the assessment phase, and then they probably also don't do some of the testing, like MRIs, looking for other issues that one might look for that might be causing some of the changes that one is experiencing, or one is being, is asking the question of the neuropsychologist for. And then also one, aside from other modalities of testing besides the neuropsychological battery, which is usually, individual one-on-one testing. So MRIs or EEG, or we do that special cognizant, or you can get fancy with PET scans, or just looking for B12 deficiency, some simple things, so the physician will kind of look for other problems. But then from the neuropsychologists don't, as far as I understand, I haven't seen one here that does it. They don't end up prescribing therapies because they don't have, they don't do medicines, or they're not as familiar, or they know some of them, but they won't be able to prescribe them, and they may not have as much experience with it, therefore.
Well, I don't know all of what comes under the heading of therapy. but I got a workbook with these various exercises you could do,
Mhm.
and that's typical of what they do, I guess.
It is,
A
and
little different.
and sort of in our practice, for example, I mean, there are situations where we may order neuropsychological consultation or testing. There are a couple here in town that we work with that are very good. From my experience with neuropsychologists, they do a very, very detailed assessment. I mean, I'm sure you remember it was a 3 or 4 hour test where you thought, my God, when am I going to get out of here?
Like 6 hours.
It's pretty relentless, and so when you look at somebody who's still very high functioning, and there may be very subtle changes that they've noticed in their own cognitive abilities, or maybe a family member has noticed, but yet when we do our simple tests in the office, who's the president, how many animals can you name, this and that, people still score in the top levels. The neuropsych examination is much more detailed and can start to show different patterns of which parts of the brain might not be functioning optimally. And that can often lead into a diagnosis. Once you go to see a physician, I've had referrals from the neuropsychologist where they would say, I've noticed a very mild cognitive impairment that fits the pattern of somebody who may be developing Parkinson's disease, which I found very interesting. So they can start to see different trends and often point towards something. In terms of, treating what the underlying cause is, they typically don't, but the therapies that you're talking about, the exercises, sometimes the cognitive behavioral therapies, they do a very good job with. So we see the neuropsychologist as a partner in what we're doing in certain situations. Not everybody can tolerate the testing because, it's an all-day affair and it's not pleasant. But that's the way we're a little bit different is we deal with the same situations. We ultimately order some different tests, and ultimately we'll try to treat what the underlying disease is with medications or whatever that.
I was hoping I could avoid the all-day tests again.
Yeah, I think one is plenty. If you've had it, we'll spot you that. So no more.
There's some comments in the box here. Somebody would like you to speak about, I'll mispronounce that, Ingebra.
So that's probably Inbrija, which is a Parkinson's medication. Levodopa, or the medication that becomes dopamine in the brain, sort of the mainstay of treatment. So Inbrija is a new type of levodopa. It's an inhaled type of levodopa. It comes in a little inhaler that you breathe in. It's very much a sort of rescue medicine, if you will. It's not a maintenance medicine that you take every day at certain times. It's specifically when your Parkinson's symptoms are flared up and your medicine's not working and you need a quick pick-me-up to get moving. You can breathe in the levodopa and it goes in through your lung to your brain much quicker. It only lasts for about an hour, but it's sort of a nice pick-me-up, because if you take your pill, it's probably going to take an hour to work. If you're stuck at Home Depot and you can't walk and you need it to work now, Inbrija is a way to accomplish that.
We have a welcome, Dr. Wu. We are excited to have you as an additional physician resource for the Parkinson's community, from Anne Marie, the Executive Director of the Parkinson's Association of the Carolinas. Thank you, Anne Marie. What are your thoughts on using one's own stem cells for Parkinson's disease?
That's a tough one.
1990s.
Right.
Did we do that in the 1990s?
You sure did.
Didn't work that well then, but we have. There's been a lot of time in between.
It's still not working that well.
Yeah.
Again, I think the issue with stem cells, was so controversial just because of where it all came from. But using your own cells, is a different story. I think really the challenges are, how do you know that this cell that could do anything is going to do what you want it to do when you put it where it is and not anything else? How do you know it's going to do anything at all? Again, I think it sounds wonderful, and it could be wonderful in the right situation if we know how to harvest it right. But I still think that's a ways away, and we're probably going to find other ways to slow progression of whether it's Parkinson's or Alzheimer's or other things, much sooner, is my general opinion.
But if you ever decide to change your current particular interest in neurology, might you move to neuropathy?
I used to do neuropathy, actually. So I did, I also, after neurology, you can specialize and you can do studies of the nerves. And I did that after my residency. So I actually did a lot of neuropathy, and it's still interesting. And we talked about whether to keep doing it here, but it also just didn't seem to be the right fit for here. So not anytime soon, I guess is the answer. But they're all, everything's interrelated. Everything's interrelated. But yeah, not anytime soon.
Okay, I am interested how to take care of my wife. She got advanced Alzheimer disease and she's on the medication, but the medication doesn't really help. Well, I don't expect any regress, but at least stop at the point where she is now. So, what kind of a medication would you recommend?
That's really hard to say from just not knowing your wife's situation. I think, is that her behind you?
Yes, that's she.
Well, that in itself, the happy wave tells me a lot that you're probably doing a great job. I'll take from Dr. Edwards the calm, clean, safe, happy, and so you're already doing, I think, a great job from what I can see. And medicines, even the new ones, although we think of them as, oh my gosh, these incredible antibodies and, or all these different things, they only do so much. You're doing so much more, and it already looks like you're doing a great job. But if you come here, we can, that might be something we can address further. But it looks like you're doing a great job.
Yes,
One thing that's always important to ask your doctors at each visit, are there any medications on our list that we can stop? Doctors are really good at addition. We're not so good at subtraction. And sometimes taking away medications that could hurt the memory or cause balance problems is just as important as prescribing new medicines. So that's something that we urge everybody to ask their own physicians. Is there anything here that we can get rid of?
just recently, like a couple days ago, maybe more than that, like 4 days ago, we were in your office, Memories and Movement, and we spent over 2 hours with very nice people out there. And I believe her stage with the Alzheimer is between 5 and 6. So it's very advanced.
So you've come for your intake visit for the initial visit and are going to be seeing the physician very soon, is what I'm understanding.
Yes, on the 2nd of November, we have a next visit. So maybe we'll find out a little bit more.
Yes, sir.
Thank you very much.
But knowing what you know and you've seen in your field and so forth, is there any recommendations or anything that you would say to the younger population from a brain health and wellness, or anything advice you would give to folks out in the community from a health and wellness standpoint?
Yeah, so I used to, when I saw, not that long ago, I saw patients from 17 on up, and once I had addressed kind of the main issue, a lot of, I'll say the younger patients, even in their 20s or that type of thing, if they came for a follow-up visit, I would take that opportunity, because I do think one of the things that we've learned is that, again, not having a problem is better, but exercise or do what you can. And in the 90s, when in the 90s when we were in medical school, we did not learn about diet or exercise, or it sounds really strange actually, but it's true. We learned about illness, but we've garnered a lot of knowledge over time. And so do what you can that's reasonable for sleep, eating, and exercise. And anything that you can do, we can worry about. There are probably tens of thousands of articles about what's the best exercise. The best exercise is 98% of it is what you will do. I'm not worried about, is it yoga? Should you do HIIT? Should it be 15 minutes? And then you walk for 5, or, it's what you will do and sustain. And then that's 98% of it. And then diet, in general, you could read, again, hundreds, thousands of books, articles. Mediterranean diet, we probably particularly say fish a couple times a week, and sleep, really, really important. We always thought it was, and the knowledge grows with that. Your brain is not only consolidating information then and building all those important networks, it's also getting rid of trash. You don't have time during the day, you're busy, so all that is happening at night. So, doing those things. And I think I also say, gosh, if we could all grow our own vegetables, and all these different things. So, you do what you can, but exercise, eating healthy, sleeping. I don't know if you have, yeah.
Often the same question when it comes to like nutrition and diet. Obviously, a lot of us know the good things to have when it comes to like cardio and things like that, or even with the heart, they tell you things that you shouldn't eat. Is there anything specifically you've come across for like the brain or things like that you would recommend not having specifically?
Probably things in excess, most things in excess. Too much vitamin B6 is bad. Alcohol in excess is, not good. But I'm trying, there are toxins and things like that. But aside from that, does anyone need Diet Coke? But is one Diet Coke once a month bad? So I'm not in particular. And
Getting us in trouble.
So.
What about like processed foods? Like would that be something you would just try to keep out entirely?
I think fresh and the fresh and Mediterranean diet, and that's part of it. If you can, part of the reason I'm not, you may have gathered, I'm not a natural athlete. So, but anyway, I exercise now, and part of it really is truly because of my reading. I realize how very important that is. And then food, yes, I think, you get your best nutrients through your diet, and fresh tends to have, we could get into, frozen, if you freeze it right away at a certain time, then actually it retains all the vegetables. And then if you don't steam it, then it stays. And so there are variations, but yes. So it does seem like processed foods. And then,
Have you seen any interesting hobbies or activities that have struck you as unique among your patients?
Oh, so many, but there are so many unique hobbies. Gosh, I can't think of one off the top of my head, but I find I love meeting people, and I think what they're interested in, and I don't know, birding, or that's not even that interesting. I'm trying to think of some interesting.
I see a lot of folks who are interested in quilting or like crochet and things that involve manual dexterity. But also it's stimulating something, up here. I'll share one story. My mother has some cognitive impairments, and my daughter will sit with her and crochet with her. And there are days where my mother won't talk to anybody. But if my daughter's sitting there and they start crocheting, the next thing you know, the stories start flowing. And so there are things that will stimulate the brain in different ways, and whether it's crochet, whether there have been research done on ping pong in Alzheimer's and Parkinson's. There's all sorts of things, but it's just things that just wake up different circuits in the brain, I think. And we like Dr. Wu said, we just love hearing about what our patients are doing, because everyone has a different story. Everyone's a different person. And that's part of the fun of what we do here. We get to know so many different people.
Do you find that as far as television watching people, do you have recommendations, old movies, comedies?
So for a person who might anything that kind of speaks to the person, that they used to love, music, of course, is one, that if that will wake people up, or anything that is familiar to them that brings back their memories, because our memories are so interesting. They're about how you're feeling at the time. We know that if you're very happy or very sad, it's coded a little bit more strongly, and then it's all integrated, and how it's integrated. And so anything that kind of wakes up different memories, and a lot of the old movies and songs will do that for people.
I tell my patients not to get stuck in a rut where they're watching the news all day. That's the worst thing you can do, honestly. So watch it once a day so you don't miss out on the big stuff, but don't watch it all day.
I'm curious about exercises that could involve recalling the distant past. One little habit I've gotten into is I test my memory long-term periodically by reciting my elementary school teachers from first grade through sixth grade.
Wow.
And I can still do it, but sometimes I work a little harder than other times to do that. Is that the kind of thing that has any benefit that you know of, or is it just, you're still able to do it and that's about it?
There are lots of things, so there have been a variety of studies about what activities may be helpful, and I think anything that speaks to you, how hobbies, you've probably heard that. That's probably because hobbies both wake that procedural memory, which may invoke other memories, and then also most hobbies take planning. You can't just, it's not going to come out. You can't plant tulips in the wrong month. You can't, that picture is not going to come out right for crochet. You actually have, there's a lot of higher functioning. And then what you're talking about, the exercises you're doing, those do seem to be helpful too.
Nobody's ever told me to do that.
Yeah.
I just thought I'd try it.
Yeah.
Everybody has a different way of learning. One of my children will sit at a desk for 6 hours and will memorize everything that's ever happened. Another child will be in the driveway dribbling a basketball, and that's how he remembers and learns. And so there's something to be said about kinetic learning, as we call it. Some people just need to be moving for them to learn new information, or to memorize, or to recall past events. And, based on how you were when you were growing up, and you look very fit, I'm sure you were very active. Maybe that's a pattern that was helpful to you back then, and that might be something useful moving forward.
So obviously I know there's a lot of things interrelated when it comes to Alzheimer's and things like that. I saw some recent studies just on basic memory, not necessarily that population specifically, but it was like kind of looking at trauma in your past and how it directly correlates to your memory now, whether it be someone in their 20s or older. Do you think that could also correlate to patients that have been diagnosed with Alzheimer's, like the trauma that they've seen in the past?
I definitely do. We're learning so much about trauma, and how even your parents' trauma, or you look at areas with famine and how that affected the children of people in famine, because the sensitivity of the receptors changed in vitro. And so there's so much we don't understand, but definitely we see that. One thing that was interesting, I think, in the field of Parkinson's to me, and maybe I just missed it in medical school, but it seemed like we didn't talk about the behavioral symptoms of Parkinson's. And I remember being in practice and thinking, and I remember in New York, it was a mecca of movement disorders. And I went off to Columbia and rotated with Dr. fan and all, the big wigs. And we didn't really talk about that. And but then I went into practice and I thought, gosh, that's the thing that bothers people the most. What did I miss? But I do think it does play a role, and it can, we see it manifesting in our patients a lot of the time with Alzheimer's, because you lose, you might have used higher functions to maybe, this is a simplification, but suppress some past trauma or work past a past trauma. And then when you lose that, that might come to the fore more. But
I think also you think about when people go through, whether it's physical trauma, head injuries, or whether it's just emotional trauma, when someone's in the height of a panic attack, that's where they can't remember anything, and you're not processing information, you're not encoding information. People who've been through really horrific situations, or people who've been in Vietnam and have seen their friends blown up and their mind is in turmoil. Often that's what causes all their cognitive issues. If you can correct that, they will function at a much higher level. So, whether it's a physical insult or an emotional insult, it all adds up and it all counts.
As you go through this first wave of seeing patients for the first time, is there any consistent theme that you're experiencing as you walk away from the initial engagement?
I'm always amazed at every time I leave a visit, I am amazed how resilient and powerful people are. That's probably, you see the families, and whether it's the spouse or a child, and I just walk away and I think, gosh, well, I did this much, but I'm glad they have so much strength.
Even if they don't recognize it.
Yeah, that's cool.
That's perfect. How do you handle the nonverbal in a dementia? My husband has FTD, and what's starting to develop, is being nonverbal, and I don't know how to handle it. He's like pointing and grunting, but it comes and goes. And then it can snap. He can snap right back into verbally. So is that something that I should insist that he talk? No,
that will be frustrating for him, and that's a really difficult situation. I don't know that there's a clear answer to it, but not insisting, because he probably won't be able to. And then the waxing and waning quality is difficult also, and that's actually common with all of these things. I think all of us have experienced where we are thinking better at certain times of day, and that's just going to happen for a variety of reasons for every person, but it's more marked for someone like your husband. Gosh, that's hard.
Yeah, it
Sometimes they talk about things like the pictures, boards and habits, and correlating pictures with certain things or needs. And I don't know if that's something that you've tried, or
sometimes if I get, if we do puzzle, a puzzle, if I get something to engage in, occasionally then he'll start talking. But the verbal piece has decreased considerably.
I think often when people have that happening, they can't control it. They don't know from moment to moment whether they're going to be verbal or not. It's just whatever is happening to be going on, and so you sort of have to meet them where they are. And if it's a nonverbal moment, then you smile a lot, you listen to music, you do things that are comforting, gesturing. But I think when you try to force somebody back into something, it never works. My mother goes back and forth between English and Hindi all day long, and my kids can't understand her when she's over here. But so we'll just wait for a little while; she'll come back over here, and so it's tricky.
So is that a scenario? I know earlier y'all were talking about medication that someone had brought up. Is that an instance that medication would be utilized for, or is it mostly just movement that medicine's been prescribed for?
The medication, meaning the inhaler?
Mm-hmm.
The inhaler is specifically for movement.
I had a question about COVID, and my wife a couple of months ago developed COVID from one of her adult daycare centers, and ever since then she's not been able to walk. Just wondered what your experience might have been, if you have any, with any other COVID patients and other things that might have.
Yeah, so there's a variety of things. It could be as simple as, and probably the most likely explanation is that when someone has been immobile or sick, it takes probably 2 or 3 times the length of time that they were sick to recover. And so that's maybe all that's going on. There's a recent article about long COVID, which you're not in that window, about how serotonin has been low, seemed to be low in a portion of long COVID patients, and there may be some GI etiology or reason for that. I had one autoimmune patient who had an autonomic, so there are these rare things, but most of the time we don't know. Hopefully it sounds like it recently happened, and it does take time to recover. So hopefully it was just that she was ill, and then will take some time to recover.
Thank you so much to Dr. Iyer and to Dr. Wu. Dr. Wu, I have to tell you, when we made the announcement that you were joining the practice, we received a lot of email from patients of yours, even from New York, who wanted to follow you here, regardless of whether their diagnosis with anything that we treat here. We literally had a patient in New York who was willing to travel to Charlotte once a year if she could see you, because she said you were the first doctor who listened to her and figured out what was going on. Unfortunately, what was going on was neither memory nor movement. But we see why they would be willing, why your patients are so devoted to you. And we're really
I feel so lucky to be here, and I already feel so at home, and just that this place for this special group of patients and people to be part of it. I feel really lucky.
We all do. Thank you to everyone who's here in person. Eat some cookies. Thank you to everyone on Zoom. Next time, join us because we have cookies. And if you registered for this session, it means we now have your email address, and you'll receive an email about next month's Take Charge Live. So thank you so much. We hope to see you again.